Okay, starting the recording, and Dr. Chongmin will give us her presentation. Thank you.
Can you hear me?
Yeah.
Okay. So, hi everyone, welcome to Chess City. Today we will learn how to read chess cities with confidence, especially when it comes to spotting lymph nodes, which play a key role in cancer staging and diagnosis. The intended audience for this is medical students. So, for the medical doctors, this may seem a little bit basic. And sorry for that in advance. So getting started, let's start with the basics of reading electricity. Here's a fun little poem to help you remember that the air is black and the bone is white, and the gray stuff is, and the soft stuff is gray, like heart and nodes. So And when you're trying to spot a lymph node, use this mnemonic. I made it up. So SPLIT. S means it stays in one spot, that it doesn't travel or change shape across slices like vessels do. And P means positioned near airways and vessels. LNs love to hang out near big anatomical landmarks. And L means it's low in contrast. They don't light up with contrast like blood vessels. And I means it's individual blobs. They don't branch or flow or connect into others like vessels. He means that it tends to be asymmetric, especially when enlarged from disease. The vessels are more symmetric. So lymph nodes and vessels can be difficult to tell apart from each other, but there are ways to discriminate. And
So
this
I
is
have
a
a question.
Mhm.
Don't light up with contrast. Isn't there a little bit of
Yeah, it
enhancement?
lights a little bit, but it doesn't go like white, really white,
Ah,
you
okay,
know?
okay.
Yeah. So when we talk about lung cancer staging, we use the TNM system. T is for tumor size and extent, N is for lymph node involvement, and M is for metastasis. And there are mainly three types of TNM. There are a lot of TNM staging depending on timing, but let's look at these three. C means it's clinical. It's based on scans or procedures done before treatment. P means it's pathologic. It's based on what we find during or after surgery. So the pathology report is what we determine the staging based upon. And RTNM means it's recurrence. This is used if cancer comes back and we need to stage it again. So understanding the difference is important for both diagnosis and research. We shouldn't like confound between the initial stage and the recurring stage. And CTNM often comes from imaging, which is why reading CT as well matters. And this is the lymph node map. This slide introduces the IASLC lymph node map. This is our roadmap for lymph node stations in the chest. Some nodes are labeled by right or left sides, like stations 1, 2, 4, 8, 9, 10 to 14. These are easier to localize side by side on CT, but others like 3A, 3P, 5, 6, 7 don't get a side label. You'll find these along the midline structures like the great vessels or trachea. I will go into depth about this a bit later. So here's a more detailed breakdown of the lymph node zones based on the anatomic region. So let's zoom into the supraclavicular zone, which includes station 1R and 1L. These are lymph nodes near the lower neck on top of the chest, right above the clavicle. The upper border is the lower margin of the cricoid cartilage, and the lower border is the clavicle or upper manubrium. So wait a sec. Can you see the page I'm looking at?
Yeah, that's nice.
Yeah, I really like this page, but it's expensive. So so this is clavicle. You can see it unlike ribs moving on this
Mm-hmm.
between the soft tissue and the clavicles contact with manubrium. So this above this level is the SCN lymph nodes. So above this level.
Hmm.
This is where you should look at, and you can, physically examine the patient and look for the supraclavicular lymph nodes. That also works. So
So where is
the
L1?
uh this is a normal patient CT, so it doesn't have an enlarged lymph node to look at.
Oh, okay.
Yeah, just look at the anatomical border. So these nodes are especially important. It's easy to look for with P if cancer spreads here, and it can indicate more advanced disease. So I think mostly like people with enlarged SCN has it like somewhere here,
Hmm.
vaguely. So look for it.
So low cervical supraclavicular sternal notch, they're all different, but they're all classified into one R, one L.
Yes.
Okay.
Hmm. So this isn't a single lymph node. It's like more of a zone.
Yeah,
Like,
so yeah.
yeah. Now we are moving down into the upper mediastinum. 2R and 2L are the upper paratracheal nodes. They sit beside the trachea in the upper chest, and the upper border of this zone is the apex of the lung, and the lower border is where the innominate vein or brachiocephalic vein meets the trachea. The boundary between left and right is the left lateral wall of the trachea. It's not the midline. So knowing this boundary is super important for correct classification. So what I'm talking about is that the lymph nodes right here in the here's the trachea, and the upper side belongs to 2R and 2L. So this is the brachiocephalic vein, the innominate vein. You can see it moving across left and right side. And what I mean by left-right border is right here. If it's like on this side, it's the 2L. And if it's on this side, it's 2R. So the lymph nodes above this brachiocephalic vein, those are the upper paratracheal lymph nodes. And those below this is the lower paratracheal lymph nodes that you will see. And 3A is zone upper, another zone from the upper zone is 3A and 3P. 3A and 3P doesn't have a right or left side. 3A is prevascular nodes and 3P is retrotracheal nodes. So retrotracheal nodes, as you can see, is uh, located in the retrotracheal region. It's like behind the trachea. And the prevascular nodes, uh, they are what like more in front of the SVC and behind the sternum. So you see this SVC, this is the sternum, and if
Hmm.
there's an enlarged node between this and this zone, in this area, then you can say, oh, that's like prevascular lymph nodes. And oh, I mistyped it. It's the lower zone. Like 4R is right lower paratracheal lymph nodes, and 4L is left lower paratracheal lymph nodes. So the boundary between the right and left is again the left lateral wall of trachea, and the 4R has a different upper and lower border from the 4L because there are different like anatomical structures in right and left side. So the 4R is below the brachiocephalic vein and it's above the azygos vein. And, and 4L is below the upper margin of aortic arch and it's above the left main pulmonary artery. So this is the brachiocephalic vein, and anything below this level and anything above this azygos vein you can see here, that belongs to the lower paratracheal right lymph nodes. And on the left side, uh, you can see this aortic arch. And if you go down, you can see the pulmonary artery emerging. So anything between this pulmonary artery and aortic arch level, like on this level, that's the lower paratracheal lymph nodes. You'll get used to it. In zone 5, that's the subaortic lymph nodes. It's lateral to ligamentum arteriosum and it's below the aortic arch lower border and above the upper rim of pulmonary artery. And para-aortic lymph nodes, they are like anterior and lateral to the aortic arch. It's like really next to the aortic arch. I will show you a real case of an enlarged para-aortic lymph node later. And the subcarinal lymph nodes is very important. Carina means where the trachea splits into two. So there is like a Korean girl group called aespa, and the center member's name is Karina. So remember, Karina is in the middle. So Karina is the upper border of subcarinal lymph nodes. It's really simple. Like the trachea splits into two, and if there's something in between here, it must be lodged between these two bronchus. So if anything is enlarged here, it's subcarinal lymph nodes. And here's the paraesophageal lymph nodes. These are found next to the esophagus, just below the subcarinal space. So we exclude the subcarinal lymph node, and the rest is paraesophageal lymph nodes. Pulmonary ligament lymph nodes, they like theoretically exist, but I've never seen an enlarged pulmonary ligament lymph nodes. It's very difficult to find. So I only know this theoretically. It's supposed to be above the diaphragm and on the inferior side of the pulmonary vein, but I've never seen it. And there are the hilar lymph nodes and interlobar lymph nodes. Hilar lymph nodes are immediately adjacent to the main stem bronchus. So it's right here. It's not between this splitting bronchus. It's right next to the subcarinal lymph nodes. The interlobar lymph nodes, it's between the origin of lobar bronchi. And there are the lobar lymph nodes, segmental lymph nodes, subsegmental lymph nodes. These are more peripheral and more local. So these nodes are very tiny and often not visible unless they are abnormally large. They are also part of the N1 category, so it means localized spread. So let's look at a real patient case. Okay. You see something enlarged right here. This is esophagus, this is trachea. And you see something right here. It's not a vessel because if you go up and down, you can see it not connecting to any other structure. It just disappears. So this must be an enlarged lymph node, and by the location, we can see that it's an upper paratracheal lymph node because it's right next to the trachea, and it's above the level of brachiocephalic lymph node. And right here, you can see a lower paratracheal lymph node is also next to the trachea. You can see that it's not a vessel, but it's on the more lower side. So just get a vague feeling of where to look for lymph nodes. It is right here. And you can see a very good example of a para-aortic lymph nodes. It's on the lateral side of the aortic arch, but it's still above the level of pulmonary artery, which you can see. This really bright thing, that's the pulmonary artery. And the para-aortic lymph node was above that level here. And right here, you can see the subcarinal lymph node. So the carina split right here. You can see the lymph node starting here. It's very big, very enlarged. So I think some hilar lymph nodes might be like mixed into this. If a lymph node gets really enlarged, it's very hard to discern from other structures. But anyway, you can see that it started off as a subcarinal lymph node. And there are like um, interlobal lymph nodes right here. You can see the bronchosplitting, and there's something thick and gray in between. I think that's interlobal lymph node a bit enlarged. Yes. Yeah, so these are basically how you look for lymph nodes. You look at something off, something that's not a vessel, something that like disappears once you move the slide up and down, and you look at the location, you get a vague feeling of, oh, it's just the upper side of the trachea or the lower side of trachea. So that's how you look for it. It takes time getting used to it. So this is how you look for chest CT. And this site is really good. It's called Imaios. I'm don't have any conflict of interest. It is good for studying because you can change windows. Like you can, look at all the structures if you want to.
Hmm.
There are a lot of structures in this chest, so unless you like go to the radiology department, I don't think you like really need to know all of these structures, but just get a vague impression. Anyway, this is the end of how to look for lymph nodes in chest CT. So the regional lymph nodes are classified like N1, N2, N3, and N1 is the ipsilateral uh, peribronchial hilar lymph nodes, and N2 is ipsilateral mediastinal or subcarinal lymph nodes, and N3 is going to the opposite side or above the supraclavicular lymph node, lower cervical lymph node. These are the regional lymph nodes, and if there is a lymph node metastasis to like abdominal lymph nodes in a lung cancer, that's a distant metastasis. So you should like know what is a thoracic lymph node. So basically, that's all for just CT. Any questions?
Thank you.
So what we should know about the chest city? What is the point?
So the point is, you should know, you should like be able to recognize what is a lymph node on chest CT. I think that's the most important thing. Like, just look at it and see what's off, what's a bit enlarged, asymmetric, something's off, and you don't want to miss that lymph node enlargement as a doctor if you see a CT. Because once I saw a small cell lung cancer patient who could have like uh gotten surveillance earlier. He received a surgery completely unrelated to the chest, and he took a chest CT before that surgery, and it showed enlarged lymph nodes, but the doctors missed it because he was asymptomatic. He was receiving surgery for a completely different condition, so they didn't think it was important. So they and like 6 months passed. He's now having extensive small cell lung cancer. And I saw the case and thought, wow, if anyone should be able to recognize enlarged lymph nodes.
Thank you.
Mhm. Okay, so let's go right into the introduction to medical research. This is a beginner's guide. This is really like for medical students. Mhm. In the next few slides, we'll cover the basics, how studies are designed, how we analyze them, and how to use this knowledge in a practical level. So let's break down like three common study designs in biomedical research. There's this retrospective cohort study. It uses past data. The data is already there, like in electronic medical records. It starts with people who are exposed to something like smoking and looks at what happened to them later. So these smokers from 10 years ago developed lung cancer more than non-smokers. This is an example of retrospective cohort study. And the case control study starts with people who already have a disease, the cases, and compares them to those who don't, controls. So it looks backward to find risk factors like did people with lung cancer smoke more than people without it? This is an example of case control study. These are observational studies and they help us to find patterns and associations. It's not causation, it's association. But it helps us get a clue. And the prospective cohort study is different from the retrospective and case control designs. In a prospective study, we start with a group of people now and follow them into the future. We track exposures and then observe who develops the outcome of interest, like a disease. So, for example, we enroll a group of smokers and non-smokers today and follow them for 10 years to see who gets lung cancer. This design is stronger than retrospective studies when it comes to causality, but it's more time consuming and expensive. So now let's talk about the null hypothesis. This is a default assumption in any research study. It states there is no difference between the two groups. For example, there is no difference in survival between smokers and non-smokers. And our goal in research is usually to try and disprove the null hypothesis. If our data shows a strong enough effect, we can say that the difference is not due to chance. That's the p-value. The p-value means that my result has happened by a chance. If p is lower than 0.05, we usually say that the result is statistically significant, meaning that there is less than a 5% chance that the result happened randomly, but a result can be statistically significant and still be clinically meaningless. For example, a drug that improves survival by just like 2 or 3 days and have a lot of adverse events might not matter to the patient if even if it's like survival benefit has a p-value lower than 0.05. So when interpreting results, we always ask that is it statistically significant and is it clinically significant? And let's define overall survival or OS, one of the most important outcomes in research, medical research. So OS is the time from a specific starting point, also called the index date, until the patient dies from any cause or until the data is cut off. So what do we use for the starting index date? It can be many things. It can be the date of treatment initiations, like first cycle of immunotherapy or chemotherapy, but it can also be defined as date of baseline imaging, date of clinical visit or decision to treat. It's defined in each study, but it must be consistent across the patient population and it must be like consistent in the um, in OS and PFS. So having a consistent index data is very important, and also interpreting the existing study. It's uh, we have to look at like how OS is defined in each study while looking at the journals. So the end date can be a date of death from any cause, or if patient is alive at last follow-up, end date is the date of last known contact when the like patient was seen at the clinic or when the phone call was made or when the patient came for imaging. The end date can be like defined at the last known contact. So if a patient started treatment on like 2020 January 1st and the patient was last seen alive on March 15, 2023 and no death was recorded, the end date would be March 15, 2023, not the time when I'm conducting the study. And progression-free survival is time from a defined starting point to first occurrence of disease progression or death from any cause. There are patients who die before disease progression. In that case, you should put death of any cause as the end date. And if neither has occurred, the patient is censored at date of last uh, radiologic imaging. Like some patients come to the office really like 1 month after radiologic imaging. You can't put that as a PFS end date. You have to like use the last radiologic imaging date because just because the patient came to the office late, it shouldn't increase the PFS. So end date is at the earliest of these three. Anything comes first. So I made a table to help understand. Oh, overall survival and progression-free survival, the start date, the end event, the cutoff.
Cutoff can be censor date.
Mhm.
Yeah. So you censor data when there is no outcome yet.
Yes, if there's no progression or death yet, you have to use the sensor data. And beyond the OS and PFS, you'll also hear about things like 5-year survival rates, especially in clinical trials. These are simple measures what percentage of patients are still alive after 5 years. But to compare risk of between groups over time, we often use a hazard ratio. If HR is 1, there's no difference between two groups. HR is less than 1, it means that there's lower risk in the treatment group. HR is above 1, there is higher risk in the treatment group. So if a drug has an HR of 0.6, it means there is a 40% reduction in risk of event in the uh, given period. And when you're analyzing research data, especially survival data, it's really important to stratify. That means breaking the patients into subgroups. Why is that? It's to look at patterns within different categories like age, sex, or cancer stage, and to reduce confounding, which happens when other variables are influencing your result. For example, maybe the treatment works better in younger patients than in older ones, or maybe it works better in early stage disease but not in late stage. Stratification helps you find that out. So let's quickly talk about how studies are typically organized. There are many different ways you can conduct a study. This is just the basic starting point. When you write the journal, the table 1 is mainly about patient demographics and clinical information. You if there's a treatment group and non-treatment group, you show demographics for each group to show how each group is similar in its demographics. Like if the treatment group is all women and the non-treatment group is all men, it isn't really comparable. So you have to show that it is comparable. And you mainly use Pearson test or Fisher's exact test. Uh, you don't know. Mm, I don't think it's very necessary to really understand the technical between technique behind these statistical analysis methods. And what you need to know at this point is to like know what to apply in each circumstances. So to compare the demographics between the treatment group and non-treatment group, you mainly use the Pearson and Fisher's exact test method. And in Table 2, you mainly show the study outcomes, often stratified by Table 1 factors. And the study outcomes are stratified using the Cox proportional hazard model for univariate analysis. And in the figure, you mostly show the survival, you visualize the survival in each groups using the Kaplan-Meier analysis. This is the main uh, statistical techniques you will use uh, while conducting a study. And this is a more practical stuff, but if you use an Excel to calculate the overall survival or progression-free survival, using a function is more accurate than calculating it by yourself. This is the function you use often. Uh, it's called date diff, short for date difference. You can use you can put Y in here or M in here or D in here. If you want to uh, know your overall survival by days, you put D in it. If you want to calculate it by months, you put M in it. If you want to calculate it by years, you put Y in it. And this is how you calculate OS and PFS. Using a function makes allows less room for human errors or mistakes in calculating. It makes consistent results. So know how to use this. And that's all for today.
Thank you. Okay. Any questions or concerns? Anything you want to add? Ronald, as you were teaching students, did you have any comments or input?
No.
What about Hangyar?
I have a question about the lymph nodes enlargement in the numerical criteria, although it's a past one. So can you, I couldn't remember the exact criteria, but it's the role of radiologist. So do you have any explanation about it?
Well, if you look at radiologic reports, it often says like there is an enlargement in like lymph node station 10, or there's an enlargement in hilar lymph nodes. I think you need to know these zones to look for, to know where to look for it when you look at reports. I think that's the main like function of knowing the stations. The pathology reports also like mention stations a lot, like lymph node number 10, number 11. You know, you need to know where they took out the lymph node from so that you can like uh, look for FDG uptakes and follow up PET CTs.
Thank you.
I think for non-radiologists, the main purpose of knowing the lymph node stations and locations is for communication.
Yeah, I agree. I agree. Yeah, I think it was all very good. Yeah. Jessica, how was the talk?
It was really good, and some of the things that Dr. Jungmin was telling me over Messenger about like Cox analysis and Kaplan-Meier, it was popping up, and I was like looking at some overviews earlier, so it was cool to see that connection, and also it was really interesting to learn about the CT scans. Felt like a new like language that I was getting introduced to. So thank you.
Thank you. Thank you. Okay, so then we'll wrap up here. And I think the clinical research is unique, and it has its own nuts and bolts and things that we take it for granted, but it's not really. It's really a very tightly managed field that, any error will lead to wrong output, and that's going to change um the I guess the application in the wrong direction. So I think we have to make sure we understand the anatomic location, what it is, how do you measure it, and how do you calculate outcome. All these are basic, and we've noticed the recent errors happening too too frequently than we thought. So I do believe listening to these talks will help you reduce errors and really learn in a more accurate way. So okay, thank you again, Dr. Chongmin. That was very considerate of you to like do this for our students. So thank you. Okay, we'll stop here.